Welcome to The Explainer. Today, we're jumping right into the high-stakes world of infectious disease crises, acting as your clinical consultant. We're bypassing the generic filler completely. Instead, we're zeroing in on those exact physiological triggers, the granular variables, and the precise interventional boundaries that literally shift critical care management and dictate survival. Let's get to it.
Here's our modular interventional ladder for today. First, we'll map out acute meningitis stratification and lumbar puncture timing forks. Second, sepsis hydrodynamics and antimicrobial resuscitation sequencing. Third, we're looking at HIV intracranial masses, specifically the toxoplasmosis versus PCNSL decision boundaries. And finally, clinical reconciliation and disruptive stewardship traps.
Module 1. Acute meningitis stratification and lumbar puncture timing forks. Let's start with the central nervous system. When a patient rolls in with that classic triad of fever, headache, and a stiff neck, your clinical algorithms need to fire instantly. Now, what's absolutely fascinating here is how rapidly these cerebrospinal fluid profiles force a strict binary decision. We're talking about the pivot between bacterial pathogens that demand immediate empirical coverage and supportive aseptic pathways. When you pull that CSF, bacterial meningitis classically hits you with a highly elevated opening pressure and a massive white count, often over 1,000 with PMN dominance. Plus, you'll see plummeting glucose under 40 and elevated protein. Viral, or aseptic meningitis, is a totally different beast. You're looking at a normal or mildly elevated pressure, a much lower white count, maybe 10 to 500 with lymphocyte dominance, and crucially, a totally normal glucose level. That profile right there immediately sets your therapeutic trajectory. And this brings us to the absolute timing rule. In a perfect world, sure, you do the lumbar puncture first. But let's say you have a 55-year-old with neck stiffness, fever, and maybe a subtle right pronator drift. You've got focal neurodeficits, or maybe altered mental status, new onset seizures, or severe immunocompromise. You have to rule out a mass lesion with a head CT to prevent a catastrophic brainstem herniation. But here's the absolute mandate. If a CT scan is required, you must draw blood cultures and administer empiric IV antibiotics. Think ceftriaxone, vancomycin, maybe ampicillin if they're over 50 or immunocompromised, plus dexamethasone, before that patient ever enters the scanner. The absolute fatal stewardship trap to avoid here? Never, ever withhold empiric antimicrobials while waiting for neuroimaging. Holding off on antibiotics just to secure a pristine CSF sample during a scanner delay is a massive error. You treat the suspected bacterial meningitis empirically and immediately. You can always de-escalate later once you have your pathogen, but there's no reversing the neurologic devastation of a delayed intervention. All right, moving into Module 2, sepsis hydrodynamics and antimicrobial resuscitation sequencing. We're shifting gears from the localized pressure of the CNS to total systemic vascular collapse. Let's get our definitions straight. Septic shock isn't just a bad infection. It's a total collapse of microvascular perfusion that demands immediate mechanical override. You're looking at clinical evidence of infection combined with persistent fluid refractory hypotension requiring vasopressors just to keep that mean arterial pressure, or MAP, at or above 65 millimeters of mercury, alongside a serum lactate greater than 2 millimoles per liter. Your primary goal is hardwired right here. Maintain that pressure gradient to keep the end organs alive. And you have exactly 1 hour. 1 hour from recognition to establish venous access, draw pan cultures, and push those empiric broad-spectrum IV antibiotics, like piperacillin, tazobactam, or cefepime plus vancomycin. This 1 hour bundle is a rigid, ticking clock boundary. If a patient is hypotensive and tachypneic, every single minute you delay delivering those agents exponentially spikes their mortality risk. This is all about immediate, life-saving stabilization. Now, aggressive volume resuscitation is your initial mandate, typically 30 milliliters per kilogram of crystalloids within the first 3 hours. But picture a pneumonia patient whose blood pressure is 80 over 40 and they're still hypotensive with an escalating lactic acidosis after 3 liters of normal saline. What do? You do not drown them in extra fluid boluses. If they're amine refractory after volume completion, force central line placement and immediately initiate your first-line vasopressor, norepinephrine, to arrest that microvascular hypoperfusion. And don't forget the source control mandate. If there's an abscess or necrotic focus driving this, you absolutely must surgically debride or drain it within 6 to 12 hours. But we have to talk about this catastrophic, easily missed variable. What if you're facing refractory hypotension despite aggressive fluids and broad-spectrum antibiotics? Suspect acute adrenal insufficiency. Think about a patient chronically on steroids for lupus or a transplant.
The acute infectious stress spikes their physiologic demand for cortisol, but their suppressed adrenal glands just can't deliver. You have to recognize the secondary adrenal crisis and administer hydrocortisone immediately. It's often the only way to restore vascular tone and reverse that refractory distributive shock. Module 3, HIV intracranial masses, specifically the toxoplasmosis versus PCNSL decision boundaries. We are heading back to the CNS to navigate the precarious neurological perfusion profiles of opportunistic focal brain lesions in advanced HIV, specifically when that CD4 count drops below 100. Consider this baseline presentation: an advanced HIV patient with a CD4 count under 100, presenting with multiple discrete ring-enhancing lesions in the basal ganglia. When you see this kind of imaging pattern in an immunocompromised patient, the differential narrows aggressively down to two primary culprits. Making the wrong move here can lead to massive structural morbidity. The key is how lesion morphology and location distinctively separate parasitic infiltration from EBV-driven oncologic masses. Toxoplasmosis classically presents with multiple lesions heavily favoring the basal ganglia or the gray-white junction. On the flip side, primary CNS lymphoma, or PCNSL, is typically a solitary, large periventricular lesion driven by the Epstein-Barr virus. But imaging isn't a definitive tissue diagnosis, right? So how do we actually proceed? Well, because stereotactic brain biopsy carries a massive risk of structural morbidity, the choice architecture forces a strict empiric therapeutic trial first. For a patient with a CD4 under 100 and multiple ring-enhancing lesions, you initiate a first-line empiric anti-toxoplasma regimen, pyrimethamine, sulfadazine, and leucovorin, for 14 days. You reserve the invasive biopsy strictly for patients who demonstrate clinical or radiological failure after that 2 weeks trial. If they fail, then you biopsy to confirm PCNSL or a rare fungal etiology. Which leads us directly into a major clinical trap. Do not utilize immediate cranial radiation or empiric steroids in these advanced HIV intracranial masses without a definitive diagnostic trial. Let's say you have a patient with expressive aphasia or discrete lesions. Deploying decoys like steroids can temporarily shrink a lymphoma. That creates a false positive for your toxo trial and fatally masks the underlying oncologic or viral issues. You must hold the line on the exact empiric sequence. Okay, Module 4, Clinical Reconciliation and Disruptive Stewardship Traps. Let's pull all of this together to systematically catalog and fix those low-frequency variables that tend to trigger cascading clinical errors. Imagine this integrative scenario. A neutropenic fever patient comes in presenting with altered mental status, unstable vitals, structural abdominal tenderness, and a fever. Their primary immune defense is practically gone, and they are exhibiting signs of septic shock. What is the precise sequence of empiric interventions? You are forced here to reconcile raw biomarker profiles against failing hemodynamics. The clinical mandate here acts as our absolute anchor. Febrile neutropenia is a medical emergency. Antibiotics with gram-negative coverage, especially anti-pseudomonal coverage, must be started empirically and immediately. You're deploying an anti-pseudomonal beta-lactam like cefepime instantly, regardless of pending CT neuroimaging or other scans. You stabilize those hemodynamics with fluids and mechanical vasopressor lines, while initiating that aggressive antimicrobial blockade. Systematically reviewing our error mitigation list fortifies the boundaries that protect patients from well-intentioned but physiologically disastrous delays. Let's recap the TROPs. Trop 1, withholding antibiotics for a CT scan slot in suspected meningitis. Trop 2, administering fluid boluses past the point of volume overload in established septic shock instead of pivoting to pressors. Trop 3, delaying definitive source control surgery because you're waiting for long-term culture data. And Trop 4, utilizing steroids incorrectly in viral or fungal CNS variants, or missing acute adrenal insufficiency when you're actually dealing with refractory shock. In critical infectious diseases, survival literally comes down to subtle interventional sequencing. So I'll leave you with this final thought. When those subtle variables shift on your next shift, will your clinical decision-making confidently lead to stabilization, or will you stumble into a disruptive clinical trap? Mastering these complex boundaries isn't just about knowing the facts. It's about recognizing the exact moment to pivot. Thanks for joining me for this explainer, and keep mastering those granular decision boundaries.